few seconds more. Good evening, friends. Welcome to our 28th webinar of Indian Arthroplasty Association. I'm happy to invite you all to this 28th webinar. We'll just discuss a few things about our conference. Let me just share the screen. Just one second. So welcome to our webinar series of Indian Arthroplasty Association. We have the present membership of our association, which is crossing 800, thanks to our dynamic secretary, Dr. Rajkumar. Just a little bit of history about our Indian Arthroplasty Association. Inaugurated in 1996 at Chandigarh under the guidance of late Dr. K.T. Dholakia. Founders had a dream propagating the science of joint replacement in our country. Dr. Dholakia, we can see on the screen, Dr. Lord, Dr. P.S. Mani, Dr. Sancheti, and Dr. Dhawan. Dr. Ranawat, who has contributed heavily in introducing us to the science and discipline of arthroplasty. We pay our regards to him. This is the 28th webinar today, and we have had in this COVID time 28 webinars. We have not stopped our education and propagation of knowledge in this COVID time also. Earlier under the presidentship of Dr. Mohanty, and then after under my presidentship. Every third Thursday of the month, we are having the webinar. These are the webinars that we have had in this year. Today, we have a webinar on Know Your Knee, a well-done primary total knee arthroplasty, which is a very important subject, especially for the younger colleagues. And let me inform you that please note the dates, important dates of October 7th and 9th, when we have a conference at Coimbatore. Big work has been done by Dr. Rajkumar on this. It will be a very important academic event, the physical meeting. And we are keeping our fingers crossed that COVID will not disturb us once again. The last webinar was very interesting, principles, techniques, and future directions in revision total knee arthroplasty. And this webinar, which is being convened by our friend from Mumbai, Dr. Ashit Shah, he'll be convening this webinar. We have our noted faculty here, Dr. Raj Sinha, Dr. Vikram Desai from UK and US. We have Dr. Krishna Kiran, Dr. Mohanty, Ashit, Rakesh, and myself. Will be giving some details of the important aspects of the knee. And I'll request our friend, Dr. Ashit, to introduce the foreign faculty very soon. And to my friends and arthroplasty surgeons in India and abroad, I'll request that become the member of Indian Arthroplasty Association. It's a very good platform. You can become the member just by going to our website, or just write an email to all these two mentioned email addresses. And I'll request Dr. Ashit Shah now to introduce the foreign speakers, and then we start our scientific deliberations.
Right.
Ashit, please.
Yes, thank you very much, Rajiv, first of all, to give me this opportunity. It is an important webinar, and we have been doing so many webinars in last 2 years. And what I felt is, we've discussed a lot of topics and we've covered a lot in arthroplasty. However, I felt very, very appropriate only to get our more and more junior colleagues involved. And sometimes they have to know about what different kind of implants we use for our primary total knee replacement. So today's webinar is mainly directed to that particular group of surgeons who want to start their arthroplasty practice. And we have an excellent faculty. Thank you very much, Dr. Raj Sinha and Dr. Vikram Desai, to join us. Raj is from California, USA. He had his education and training there. Orthopedic training was in Philadelphia at famous Thomas Jefferson Institute. And since then, I was just going through his CV, and he's held multiple academic, clinical, and administrative positions in orthopedic surgery. From 2014 to 17, he was vice president of Star Orthopedics. And from 2017 to date, he is the president of Star Orthopedics, which is one of the private companies in USA. He has been a member to WOS, WHKS, and a huge number, which I cannot elaborate here because of lack of time, organizations. And he has been invited faculty to lots of platforms. So this is just in brief, Raj. I'm sorry, because of shortage of time, I cannot keep on elaborating, but can I invite you to first give us a talk on basics of implant designing and materials, including metals and plastic. Over to you, Raj Sinha from USA.
Thank you very much for the introduction. It was more than was necessary. Let me share my screen here. There we go. I think you can, I hope you can all see that. So I've been tasked with talking about total knee replacement design and some of the aspects of how do you know which implant makes the most sense for you and your patient, and what is some of the history that's been behind it. So just by way of disclosures, let me just show you what my current relationships are with industry. I'm currently a design surgeon for Conformis and Max Medical, and a consultant for DJO, and I've had previous relationships with all these companies. And I'm very happy to give this talk because this is something that's near and dear to my heart. As you can see here, this has been my experience since 1998 of all the different implants that I've had a hand in designing, and all of these implants have made it to market. There are several other implants that I had a hand in designing that didn't make it to market. Some of them, thank goodness, that they did not make it to market. As we learned in the laboratory, they just didn't make very much sense. But to get a sense of what I'm going to talk about a little bit today, I'm going to talk about some of the design characteristics over the last 50 to 60 years of knee replacement and some of the material considerations. As you can imagine, each one of these topics is a webinar in and of itself, and we can spend 4 hours talking about each of these and the exhaustive literature on it. But in a 15-minute talk, I'm going to try to hit the highlights and give you some takeaway points. So I apologize for the blurriness of this slide. This was taken from a paper published in Journal of Arthroplasty in 2005, which just went through the history of design going back to 1968 and all the different significant designers who worked on different aspects of knee replacement design. And you can see all these different implants have been put into patients with varying degrees of success. But if you look at all of them, initially, the designers of knee replacement started with a concept of, do we go with a functional outcome or do we go with an anatomical restoration? And they chose these pathways by going through different aspects of design. And the upshot of all of this, 60, 70 years of research, is that there are certain common design themes. And the common design themes are the following. Number one, and probably the most important, I think, is low polyethylene stress is very important. And you achieve this by getting a high contact area. We know that polyethylene does not stand up very well to high point contact stresses. And therefore, if your design of knee replacement has sharp edges or causes focused points of pressure, the polyethylene will not survive. So low contact stress in the polyethylene is important. The initial designs of knee replacement were sort of symmetric from flexion to extension, and therefore they did not achieve more than 90 degrees of flexion. Well, patients don't like that. So whatever design you have, it needs to allow some degree of high flexion. Most designs achieve this by having a tapering posterior condyle that allows the clearance as you go into deep flexion and still maintain low contact stress. The instruments need to be accurate. It's hard to believe for young arthroplasty surgeons. Even when I started my career, we didn't have very many instruments. And often there were systems that only came with 3 sizes of knee replacement. Hard to believe that in the 1980s and 90s that was the case, but that was the case. So we know that you need really good accurate instruments and you need to have multiple sizes. In terms of the instrumentation, I think the two most important cuts are the distal femur and the proximal tibia, because that affects both your flexion extension spacing. And the scope of talking about technique is outside of this talk, but that is critical for achieving a good outcome. The implants have to achieve stability after you've done deformity correction. For you surgeons in India, you know this. The patients you are seeing have much significant more deformity than the patients we see in the United States. And once you've corrected the deformity, you have all kinds of different situations with ligament balance, ligament tension, ligament integrity, and therefore the implants themselves have to be able to confer some degree of stability in the face of any ligament situation. The fixation must be durable. It doesn't make sense if you do a knee replacement and it only lasts 3 to 4 years. So whichever fixation you choose, whether it's cemented or uncemented, it has to have a good track record of durability. And knee kinematics, this is something that surprisingly early designers talked about this a lot, but because of manufacturing restrictions, they couldn't do much with it. But in the last 15 years or so, we've been talking about kinematics and the fact that how the knee feels to a patient, not surprisingly, correlates with how that patient functions. And so kinematics has become very important. So let me just talk about kinematics briefly. Again, there's been a lot of research done in the last 20 years, and I could go over 100 papers, but let me just summarize them for you. In terms of what's desirable, these are the things that are desirable in a total knee. We want the knee to dwell medially, meaning that on the medial side of the arthroplasty of the joint, the condyle should remain in a relatively stable position. It should not move forward. It should not move backwards very much. However, we want lateral rollback on the lateral side, because to gain high flexion, there has some degree of rollback has to occur. And if you look at the native knee in deep flexion, 155 degrees, et cetera, the lateral condyle is not even touching the lateral tibial plateau. It's completely off of the plateau. So to achieve that degree of high flexion with the anatomy that God has given us, you have to achieve some lateral rollback. And lastly, patellar tracking is very important. If you don't have good patellar balance, the patients have a significant percentage of anterior knee pain, anterior crepitus, anterior grinding, and in some studies that is as high as 25 to 30%. Well, that is a big dissatisfier for patients. Things that we do not like in total knee replacements, and there are designs still out there that do this, are things like paradoxical motion. That means as you go into flexion, the medial side moves forward. That is completely anti-kinematic, and the patients don't like it. Any sort of posterior impingement will affect flexion, and therefore you have to eliminate implant impingement as well as anatomical impingement. Patellar maltracking, as I mentioned, is critical. If you're doing a CR knee, you have to learn how to balance the posterior cruciate ligament. Otherwise, you have something called kinematic conflict, which prevents flexion of the knee. And if you're doing a PS knee, more commonly, if you don't balance the flexion and extension space, then you can have flexion instability, which is very dissatisfying to the patients because it causes recurrent hemarthroses and effusions. Or even more subtly, you can have mid-flexion instability, which means from about 20 degrees to 60 degrees, the knee feels unstable. And since most of our activities are in that position, the patients have a limitation in their function. And then liftoff is another thing. It depends upon design, but most patients don't like the feeling of liftoff because it makes them not trust the knee very much. Depending upon the shape of the femoral condyle, liftoff may or may not be a problem in terms of polyethylene wear. So a lot of the data on knee kinematic really started with this work that Richard Comestek at University of Tennessee, he's there now, but he started this work in Colorado with a surgeon named Douglas Dennis. And so what they did was they were able to get CAD drawings from the implant companies and then create a CAD overlay during a fluoroscopic imaging. And they will actually watch the knee move through the range of motion as the patient was walking, and they can tell what the kinematics were. And they were one of the first group to describe liftoff, which you can see here on the right side, where this implant is lifting off asymmetrically. And so whereas this polyethylene space should be symmetrical and even, it's asymmetrical, and the patient will feel that and not be happy about it. Whether you do a CR knee or a PS knee, there are different methodologies to achieve the sort of kinematic goal that I was talking about. So you can see here on the left image, the left side of the image is the medial side, and this is where you want the femoral condyle to dwell. You don't want it to move forward or backwards. You want it to stay in a 1 or 2 millimeter position. Whereas on the lateral side, you want this to roll back. And if you're a CR knee, Sometimes this will be achieved by having an anterior lip on the medial side and a posterior declination to allow the femur to roll back. If it's a PS knee, then oftentimes the post will be positioned and oriented and shaped in such a way that as the cam of the femoral component hits the post, it will roll back and achieve that high degree of flexion that patients are looking for. I added this image here on the right just to basically show that a lot of the work that has been done in robotics and in cadaver labs. And so the criticism has been, well, in the patient function, in the patient who's actually using the knee, do they have the same sort of kinematic profile? And the fact of the matter is it's very similar. So that's good to know. In terms of PS versus CR, I think this argument and this debate, in my mind, has been settled. They both work. The techniques are slightly different. There are some similarities, there are some differences. And regardless of which one you're going to choose, you have to understand the personality of your implant and the personality of your operation. And therefore, just generally speaking, the PS, the extension and flexion gap balancing is extremely critical. You want to avoid any sort of looseness and flexion because that causes the patient to have instability and recurrent effusions and hemarthroses. If you raise the joint line in PS, which is more common because of the ligament balancing technique, then the patella will have a tendency to maltrack and you can cause mid-flexion instability. And so one of the things that I've learned over the years when I'm doing a PS is that I really want to make sure that my femoral position in terms of distal position is not raised. I don't move that proximally at all. I'm very aggressive to make sure that I don't move the femur proximally when I'm doing a PS knee. In terms of the CR knee, and there are indications in which I will do a CR knee, but in terms of the CR knee, balancing the gaps is important, not as critical, because as long as the PCL is intact, you have a little bit of leeway in flexion space. However, if the PCL is tight, then it causes kinematic conflict and that blocks flexion. If the PCL is loose, then you can get this mid-flexion instability and flexion instability, which again causes recurrent hemarthroses and recurrent effusions. Because of the way the CR knees are designed and the way the sizing is done, in most systems, notching is much more common. So you have to be careful that when you make that anterior femoral cut, that you're not going to notch, especially on the medial side. A little bit of a lateral notch seems to be well tolerated, but if you notch the medial cortex, then you're setting that knee up for a supracondylar femur fracture later on. The other thing with the CR knee is that the polys are less conforming. And because the polyethylene is less conforming, again, as a ligament balancing enthusiast, I would argue that in a CR knee, it's just as critical to balance the gaps and balance the medial and collateral ligaments. But the CR enthusiast will often say it's not as important because since the polys are less conforming, you still get the flexion that you're looking for. Again, in terms of bearing surfaces, I know there's a talk later today about bearing surfaces. I think in the United States, this debate has also been settled. Our patients do not see much benefit from the mobile bearing. And so the fixed bearing, which was the gold standard, has remained the gold standard. Again, generally speaking, there tends to be less backside wear if there's a good locking mechanism in the tibia. With the mobile bearing, it may be more forgiving if you have slight problems in rotation of your tibial component. In reality, the studies show that about 10 degrees in either direction is about what you get once all the scar tissue has matured. Then in terms of design, again, this is a very interesting concept. So historically, the multi-radius shape of the femoral component has been the gold standard. And this basically comes from initial anatomical studies done by Harlan Amstutz, where they basically showed that the knee has multiple instantaneous centers of rotation in terms of its shape. And so the early designs were multi-radius. There were some early single radius designs as well. This was sort of a functional group of patients, but they didn't have very good stability. And so the single radius went away, but then it came back because we found that with the multi-radius design, there was a significant percentage of patients who had persistent anterior pain and they had persistent quadriceps weakness. And so the idea with the single radius was by pushing the curvature of the femoral condyle out further throughout the range of motion, it pushes the patella away from the center of rotation, and that increases the mechanical advantage of the extensor mechanism. More recently, there's been this more gradual curvature concept, which is specifically designed to eliminate the midflexion instability that you sometimes see in other designs. I would argue that it's not that midflexion instability is not a design problem, it's a surgeon problem. If the surgeon does a good job balancing the gaps and not raising the joint line, they will eliminate the midflexion instability. So as I mentioned, this was the paper from 1975 by Harlan Amstutz and his student, Dr. Mensch. And they basically showed that if you look at the distal femoral condyle, this is the medial side. In the sagittal view, there are basically two radii of the femoral shape. You've got this large red circle that I added in here that shows the more anterior aspect or the anterior radius of the femur. And then on the smaller thin red line that I've added on here, it shows the posterior radius of the femoral condyle. Now on the lateral side, you have the same concept, but the shapes are a little bit differently. And I think some of this concept of having a posterior circular radius has led to the whole concept of kinematic alignment, which again is a whole webinar in and of itself. But I think there's some merit to that based upon just the historical knowledge of shape. And so if you look at a multi-radius total knee, you see that you've got a posterior circle and an anterior circle. They are different radii. If you look at the single radius, the posterior and the anterior is the same radii. And then if you look at the more gradual one, there's multiple radii, but the idea is to keep more anterior displacement here so that you avoid the midflexion instability. Again, a lot of research has been done on all of these things. The whole concept of single radius design came from kinematic studies from Scott Banks's lab and Andy Hodges' lab. And that's when these were introduced. I've tried all of these. I've tried anatomic. I will tell you that the literature and my own experience basically says it doesn't matter which one you use. They all work equally well, or they all work equally poorly, depending on how well you, the surgeon, do the operation. More recently, the medial pivot concept, again, has been introduced. Now, this is a fixed bearing, but because of the much more rounded shape of the medial femoral condyle, almost like a tennis ball, what you wind up getting is you get a medial dwell point. And so the knee will not have paradoxical motion on the lateral side. And then even more recently is this concept of an anatomical femur. So this actually recreates each of the 3 J curves of the distal femur. You have an offset condyle distally, offset condyle medially, and the polyethylenes match that. The idea behind this is that you get a more favorable kinematic profile. So looking at all of those things from a shape standpoint, the newer medial pivot and the anatomic seem to have some benefit in terms of improving patient outcomes. It remains to be seen if those outcome benefits persist in the long term. Just briefly on material considerations, these are the materials that you'll see from a metal standpoint. Cobalt, chromium, molybdenum is the gold standard. It's been around since the 1930s. Titanium, zirconium, and nitrided titanium have been introduced within the last 2 decades on the femoral side. The tibia side is almost universally a titanium. And the reason is because the titanium is softer and it's easier to create a good locking mechanism and machine a good locking mechanism of the tibia. You can do it in cobalt chrome. It's more difficult and it's more expensive. However, if you're doing a mobile bearing, you have to do cobalt chrome, otherwise, because the titanium is too soft and there's too much wear damage on both the titanium surface as well as the polyethylene surface. But by and large, almost all fixed bearings on the market now are titanium on the tibial side. So briefly on the femoral side, as I mentioned, cobalt chrome is the gold standard. There's a lot of experience with it. Zirconium was introduced because of problems with polyethylene wear. It turns out that the polyethylene wear problems had to do with the polyethylene, not with the metal counterface. And so although you have good survivorship with the zirconium, it seems to be the same as compared to cobalt chrome. The titanium nitrided surfaces, again, were introduced to diminish wear of the polyethylene. Again, excellent survivorship. Outcomes are equal at the 2 to 5 year standpoint, comparing titanium nitrided surfaces to cobalt chrome, both in terms of patient outcomes, survivorship, as well as types of wear particles and number of wear particles. So I think this is dealer's choice. In my hands, zirconium and titanium nitrided surfaces are reserved for those patients who have a known metal allergy. As you know, most of the metal allergy that we see is due to nickel in the cobalt chrome ore. And therefore, if a patient has a true metal allergy, you want to stay away from cobalt chromium. And that's where the zirconium or the titanium nitrided surfaces become very valuable. Knee replacement is different than hip replacement in terms of polyethylene. In the hip replacement, highly cross-linked polyethylene and vitamin E infused polyethylene have definitely been shown to be an improvement because the wear particles are different in the hip. In the knee, when you compare highly cross-linked polyethylene to conventional polyethylene, again, there seems to be there's no difference in the revision rates, the type of particles, or the amount of osteolysis that we're seeing when you compare highly cross-linked to conventional. One of the problems with highly cross-linked was there was this belief that highly cross-linked was weaker, and therefore vitamin E was added as a stabilizing agent to improve the strength. And again, in vitro, the vitamin E works very well. The data thus far is equivalent. Again, there's no reduction in the type or number of wear particles. And so I think it's dealer's choice in terms of which polyethylene you're going to use. They all seem to work equally well. Again, ultimately, as my mentor, Dr. Richard Rothman, used to say, good surgeons have good results. And Dr. Booth used to say, you can put an implant in upside down and backwards, but if you balance the ligaments, it'll work well for at least 2 to 3 years. So I think what I'm trying to say is good surgery is ultimately the key here. And just a brief word on fixation surfaces. Again, I think cemented fixation is the gold standard. We're seeing more and more movement, particularly in North America, towards uncemented. I think this has to do with a lot of non-patient factors. It has to do with the surgeons wanting to have the surgery done quicker and trying to decrease infection rate and things like that. So if you're going to do an uncemented knee, you have to have a good porous coated structure, whether it's hydroxyapatite coated or not, does not seem to make much of a difference based upon the RSA studies. The potential advantage on cemented fixation is that there's no third body wear from cement particles. But again, the trade-off is there's a higher rate of loosening and there's more pain that patients feel for the first 6 months or so compared to a cemented fixation. So to conclude, the kinematics matter. That seems to be the most important thing. The femoral shape doesn't seem to make that much of a difference in the kinematics yet. It may turn out the medial pivot and the anatomic have advances, but we're waiting to see that. Whether you use posterior stabilizer, cruciate retaining, that's dealer's choice. Fixed bearing versus mobile bearing seems to be dealer's choice as well. I talked about the multi-radius, single radius issue. Outcomes are equal. The femoral material really doesn't matter in the long run. They all seem to have good durability and good fixation. And lastly, surgical technique trumps all. Good surgeons have good results, do a good operation, you'll make any knee replacement sing. Thank you very much.
Thank you, Raj. I think it's a wonderfully explained discussion about the materials and the designs of various types of the knee implants. Any comments from the faculty?
Rajiv, we are taking the questions after the second invited talk.
All right. Okay.
Because Dr. Vikram may have to go. It's a working day for him.
All right. Sure.
So he is very much there online. Can I welcome Dr. Vikram Desai, who is our second speaker? Dr. Desai is currently working at King's Mill Hospital in Mansfield, which is in central UK. He had his initial training here in India, his MBBS and MS, and then he went to UK. And he's been a consultant surgeon after finishing his training in Nottingham and Bristol since 2000. He has been very active in training and various tutor posts. His main interest is for young arthritics, patellar instability, etc. He is part of a TopKit trial also. In his own hospital, he is a service director. He has been clinical governance lead and has been on various academic and clinical posts. So can I welcome Dr. Vikram Desai, who's going to talk to us about cementing techniques in primary total knee replacement. Vikram, all yours.
Thank you very much, Dr. Ashit. For a moment, I did not recognize myself when you were saying so many things.
You'll have to share your screen.
That's it. Just about to. You should be able to see that.
Yes.
Yes.
Perfect.
Okay. Look, thank you very much. It is a very hard act to follow Dr. Sinha's excellent talk. My talk is all about cementing techniques. So it is directed mainly at newer surgeons. I hope I don't offend any of the very experienced surgeons who are there in this meeting, because I'm talking largely about something that should be reasonably basic, but we should do it properly. So cementing techniques in total knee replacements. And as you know, this is coming from sunny Mansfield, where we are having a heat wave at the moment with a temperature of 25 degrees, equal to Mumbai winter, I suppose. But we are in the heart of Sherwood Forest, and we are Robin Hood County, and this is my hospital, and this is where I am. So what is bone cement? And by and large, I think we all know that it is an acrylic polymer, and it acts as a grout or a space filler. So when it actually cures and solidifies, it expands and therefore increases the resistance between the bone surface and the implants. It also helps transmit the load from the implant to the bone. And we know it works best in compression. And if there is unsupported bone cement, it is of no use. And one of the other important bits is that it requires a continuous mantle. If there are breaks in cementing surfaces, then it can lead to debris going in between the implant and the bone, which can at some stage help loosening. Very important to remember that it is not a glue or an adhesive. It does not stick to anything, and we should not be thinking about it in that sense. Bone cement, by and large, contains very similar stuff. It is a methyl-methacrylate copolymer in the powder with an initiator and something that is radio-opaque that we can see on X-rays. And more frequently than not, we tend to use antibiotic-loaded cement. The liquid has got a monomer and an accelerator and a stabilizer. And throughout the history of cemented arthroplasty, this is the one component that has not changed its nature at all in terms of composition, or we have not been able to find a better alternative. Of course, there will be proponents who talk about uncemented implants, and they are beginning to start using uncemented knee replacements, but as yet, cemented knee replacements is still the gold standard. So what do we have to do? The first thing to do in a knee replacement is, after having made the appropriate cuts, is to prepare the bone surfaces. And you can see that the femur over here is very clear, whereas the tibia still has some blood inside it. So my preference is to use pulse lavage to take out all blood, to take out any debris. And the most important bit that weakens bone cement is marrow fat. And often when you lavage or you wash a joint out, you will find fatty globules that come out. And if nothing, the most important bit is to get rid of the marrow fat. And after that, to dry the surfaces. There are commercial ways of drying these surfaces, but a large swab always tends to work. I will often use these little keyholes inside the bone. Now, keyholes are very useful, but the important principle about a keyhole is it has to be as wide as it is deep. So there's no point in making a 2 centimeter deep keyhole when it is only 1 millimeter or 2 wide. For it to work optimally, they have to be the same diameter as well as the depth over here. So getting the bone cement ready is important. Different cements do different things. By and large, you add liquid to the powder, but in some cement compositions, it is advised to add powder to the liquid rather than the other way around. We tend to mix it in vacuum so that it minimizes air bubbles within the cement, and it does not affect the cement properties. The cement that I tend to use, we mix for 45 to 60 seconds, and we do it evenly. There are different cements, I'm aware, which you might need to mix for a bit longer. Polymerization starts, and it's an exothermic reaction, and we have a mixing time, a handing time, and a settling time. By and large, we use powder and liquid mixed in a bowl which is connected to an outlet and a vacuum pump. We have a mixing time, a working time, and a time that the cement takes to set. So when I handle cement, I always have wet gloves because otherwise the cement tends to stick. And I've got this just to show that the undersurface of the tibia does have various porous surfaces or ridges, which are very important. I'm going to play my videos if that's okay. So over here, I'm putting the cement all the way into the keel that has been made. And then with my hand, I try and punch it and I try and pressurize the cement into my bone network that we can see the lattice work of the bone medullary canal. I also add cement to the undersurface of the tibia. And I add cement all the way around the stem as well. This video doesn't show it, but I add cement everywhere. You can never have too much cement. So I always tend to cement all surfaces. Let me go back to my next slide. Bear with me. Yeah. In terms of cementing the femur, I also do the same thing. I fill cement in all the cavities. So the peg holes that are there, if there is a box that is made for a PS, and certainly on the anterior chamfers, I always put lots and lots of cement everywhere. And you can hear that's in the background, somebody is counting the time for me. And so I have a rule that when I'm cementing, the first mix for the first 45 minutes to 60 seconds, 45 to 60 seconds, and then every 30 seconds somebody is counting, because I have a time between 1 minute, 1.5 minutes when I can start handling the cement until 5, maybe 6 minutes when the cementing, but after which I cannot do anything. So all my components need to be handled and cemented in place by that time. And there are different types of cement. You can get different cements which have different mixing time, different working time, and different setting time. You can get fast setting cements and you can get slow setting cements as well. You can get cement which is very, very runny, or you can get cement which is moderately gooey. Cement comes with different antibiotics, but the standard is most of them come with gentamicin added into the powder. And the reason we add gentamicin is pre-added is because the cement curing process being an exothermic reaction, gentamicin is most resistant to the heat that is generated between 76 and 80 degrees of heat generated when the cement cures, and gentamicin doesn't denaturate or does not get destroyed. If you want to mix any other antibiotic powder to the cement, it is important to remember that that antibiotic should be able to stand the heat and must not weaken the properties of the cement. But if I have a very tight knee, I will tend to cement the tibia and the femur in 2 different mixes rather than 1 mix. And I always tend to use either a 1.5 mix of cement or 2 whole mixes of cement, even if I'm doing them together. Once I have my implant in position, I tend to pressurize in 45 degrees of flexion. And the reason I do that is that 45 degrees, the weight-bearing transmission is through the center of the tibia, so that the tibia does not rock. However, some people do pressurize in full extension. But the important point to get over here is, whilst the cement is curing, not to keep moving the knee replacement, because otherwise it adds a rocking motion and may cause loosening of the implant earlier on. As I said, I would do femur and tibia either in 1 continuous mix or 2 different, so that I would finish the tibia first and then I would do the femur. At the end of my cementing, I like to see lots and lots of cement around the implant. And I also sometimes will see cement coming out from the drill holes that are used to hold my jigs in position. And every surface, every hole that I have around the implant, I cement. Even around the patella, I thumb pressure the cement into every nook and cranny I can, so that I have an even mantle of cement. The one thing you want to avoid is a cement wedge, which is a sign of an imbalance of a knee. And if you have too much tightness on one side, then the implant may rock and may cause excessive cement on the other side, which predisposes it to early failure. And thank you for your kind attention.
Thank you, Vikram. Thank you very much. If you just stop share, yes. Okay, so now we have some good about 5 minutes for discussion on both the topics. So if anyone has any questions, you can ask either to Dr. Raj or Vikram.
Raj, you had a wonderful discussion about the anatomy and the development of the various implants. Now it's interesting that mobile bearing joints are have been common, and then they have gone back into the disrepute. What is your personal experience on the mobile bearing knees?
Well, I would say I don't think mobile bearing knees have fallen into disrepute. I think what we've learned, especially in North America, everything now is about patient outcome and patient satisfaction. And so when we study it from the standpoint of that perspective, we're finding that the mobile bearing knees are having the same outcomes.
Right.
So I don't have any particular animosity towards mobile bearing. In my experience is limited. I helped design an early version of the LCS posterior stabilized rotating bearing. So if you recall, the LCS was a cruciate retaining design with a central pivot peg. So we added a posterior post to improve lateral rollback, which was a disaster because there was so much lateral rollback that the anterior edge of the poly was cutting the capsule. So it caused a lot of pain and recurrent hemarthroses. And we wound up revising most of those patients and actually took it off the market probably within 1 year of introducing it. So that was my only negative experience with it. But I think other designs are useful. And there are certain situations where I think a mobile bearing is helpful. And the situation there would be somebody who has a very small tibia, for example, where to get proper rotation of the tibial component, you would necessarily have to have the tibia overhanging the cortical bone, which would then cause soft tissue impingement and particular pain. In that situation, you could cheat the tibial component slightly internally rotated with a mobile bearing device because the polyethylene will then sort of self-correct back to a normal, correct rotation, if you will. So in my hands, that's about the only instance where I consider a mobile bearing. Most of the time I do fixed bearing.
Now, Raj, do you have any, generally the mobile and the high flexion knees that all are in market, majority of them which have very good track record are mobile bearing high flexion knees. There are very few fixed bearing high flexion knees. And a few years ago, there was a paper that was published from Korea where it said that fixed bearing high flexion knees have a higher chances of failure at 5 to 10 years. So what do you think about this fixed bearing high flexion knees that are there in the market?
Well, I think most of the failure with high flexion fixed bearing knees has to do with fixation failure. So if you stick to the principles of cemented fixation that Dr. Desai very nicely went through, you'll get excellent fixation. And I think you'll eliminate that risk of early failure. The polyethylenes seem to stand up very well. So it's not the polyethylenes that we're seeing as the failure mechanism as much as it is the fixation. Again, I think things are a little bit different for your surgeons in India because your patient population requires so much more flexion to be able to do their daily activities, whether it's praying or sitting on the floor to eat, things like that, which are commonplace in India, but not commonplace in America. So the North American perspective is a little bit skewed, I would say, but I think there's no harm. There's nothing wrong with a high flexion mobile bearing. I think if you have a good design high flexion fixed bearing, there's nothing wrong with that either.
Can I add something?
Yes, Subhanshu.
I agree with Raj that sometimes the mobile bearing knees are little forgiving that you put the mobile bearing tibial base plate as per the availability of the bone, and your insert will adjust to the rotation. That's a good. I'm a great fan of mobile bearing knees. There are two things where I avoid using mobile bearing knees is number one, when the ligament balancing is not very good, their chances of polyethylene will spin out. And number two, mobile bearing, the tibial base plate, the post is quite smaller compared to fixed bearing knee. And I see in little, overweight or the obese patients and along the tibial component, it goes into a septic loosening, probably due to more of rotational stress in the, tibial base plate. So nowadays I'm avoiding using a mobile bearing knee in obese patients, especially if the BM is more than 30. So I'm preferring to use a fixed bearing knee because the post length is smaller compared to the fixed bearing knee. The other two things.
I think that's an excellent point. And I think I didn't do enough justice to the mechanism of failure, because there is a polyethylene dislodgement mechanism of failure in the mobile bearing. It's what we sort of talk about is not so much just general BMI, but we talk about something called the calf to thigh ratio, which is at which point does the patient's calf impinge upon their thigh in flexion. Because if they're a heavy set patient and the calf is touching the thigh early in the flexion point, then there's a huge anterior moment, and that seems to cause pain, of course, but it can also cause subluxation. And in a posterior stabilized knee, you can actually see the femur jump the post in that scenario, which I think happens sometimes in the mobile bearing. So I think that's an excellent point.
Dr. Desai, what is the situation of uncemented knees now in UK and its statistics in NJR, which is normally the reference that we all also take sometimes?
Thank you. In terms of statistics in the uncemented knee, the LCS is the only one that is currently available. Everything else is experimental. So as such, by and large, I would say 99% of us will use percent of usage is cemented knee replacement, and the NGR beds are out as well. However, if you give the surgeon a new tool, they will want to experiment it. And if you give them a hammer in their hand, they will want to find a nail on which to bang the hammer. When surgeons get bored, they will try new things. And that is how innovation happens as well.
Ashit, can I ask a question?
Of course, Rakesh.
There are a couple of questions on the chat box also. I think we can come to that. But a question for Dr. Vikram Desai. How important is it to use the vacuum mixing for knee? And do you use a gun actually to put it the cement anywhere? I know your video you didn't show, but do you actually use a gun?
So in terms of knees, in terms of knee replacements, I don't tend to use a gun. But I always vacuum mix, and there is lots of evidence to say vacuum mixing gives you a better quality of cement because it takes away the air bubbles. If you don't vacuum mix and you mix in a bowl with a sort of spatula or a spoon, you can get porous cement, and it weakens the cement, makes it a little bit more brittle. And it is vitro studies have shown that it definitely weakens the cement, increases the chances of busting. So that's why I always vacuum mix, but I don't tend to use a gun. It's not a bad thing. If you know how to ice a cake, then using a gun to coat the surfaces is actually a good thing.
Mr. Desai, do you use hydrogen peroxide anytime to dry your bone?
No.
Commonly used in Wrightington.
I think it's banned in the UK.
So in Wrightington, they commonly use for the hip cementing. Of course, when I was there, that was
it got banned a few years ago. Yeah.
So a couple of things about hydrogen peroxide. Firstly, it is extremely toxic to all the tissues that it comes across. So if you use hydrogen peroxide, it tends to harm the tissue around, affects its vitality, and can cause a little bit more necrosis, maybe at a smaller level, but not. The second thing is that if you actually look at hydrogen peroxide, it cannot be sterilized. So because hydrogen peroxide cannot be sterilized, if you're going to use it in your joint replacement, you have to be reasonably certain that the hydrogen peroxide that you're going to get has been produced properly and does not introduce any kind of contaminant to your joint replacement. So, and as Dr. Rajput said, that it has been banned. So nobody uses it. Once upon a time, we did use them, but as we've learned more, we've got rid of it.
Ashit, there's something on chat box. Shall we take that?
It's been answered. It's been answered.
Okay. Okay.
So, any more questions for our invited faculties? If not, then shall we go ahead with the next rest of our program?
Yeah, sure, Ashit.
Yes, okay. Right. Kiran, thank you very much, Dr. Raj. Thank you, Vikram. You are more than welcome to stay, or if you have any other clinical commitments, there is no problem.
If I can take your lead.
Thank you.
Thank you very
Sure.
much for your invite.
Thanks, Vikram. Thanks,
Forward to
Vikram.
staying for a little bit. Thank you.
No problem at all. Thank you. Thank you very much. Right. Okay. So now we have our own Indian faculty. First is Dr. Krishna Kiran, who is going to speak to us about the medial pivot. What is happening? Medial. So CR, PS, and medial pivot knee designs. So now these are going to be back-to-back five talks, and then we take the discussion right at the end. Krishna Kiran, all yours.
Thank you very much, Dr. Rashid, Dr. Rajiv. My brief is to talk about CRPS and medial pivot, and my job has been made pretty simple by the preceding talks. I will, however, dwell on the basics of the anatomy of knee kinematics. So if you look at the normal knee, you have the medial femoral condyle, which has got predominantly 2 radii of curvature, and the lateral, which tends to be a single radius. The medial condyle is more distal and more posterior, and this automatically causes more sort of a congruency on the medial condyle, and the lateral condyle being smaller tends to have more translation. So if you look at the normal knee kinematics, with increasing flexion, the lateral femoral condyle translates more posteriorly. The medial condyle remains more or less constant, and this lateral femoral condyle is aided by the mobile lateral meniscus to slide off the part of the posterior lateral part of the femur, and this gives deep flexion to the normal knee. If you look at the normal knee as well, we have the 4-bar linkage model between the ACL, PCL, and medial and lateral collateral ligaments. And the most important thing which is missing in a conventional total knee replacement is the ACL. So although the PCL has been retained or substituted in several of these designs, the lack of ACL is the one which tends to be the clincher with respect to how the kinematics are never replicated following conventional total knee replacement. Now, if we retain the native posterior cruciate ligament, then that is called as a PCL retaining implant. And the design considerations transited from a round on flat articulation in order to prevent kinematic conflict, as was talked about, to a more or less reasonably curved configuration of the polyethylene nowadays. And it is extremely important to balance the PCL to avoid kinematic conflict. By kinematic conflict, it indicates that with the PCL function, the femur tends to roll back with flexion. And if you have a more conforming articulation, then that sometimes tends to prevent the posterior rollback, which is desirable for increasing knee flexion. And this is the kinematic conflict which has been talked about. Several proponents of PCL retention have suggested that there is better proprioception. There is also a theory which suggests that the isolated removal has got an unpredictable increase in the flexion gap. So this can be difficult to balance the flexion extension gap balancing when you sacrifice the PCL. And the PCL can aid in natural rollback when it is balanced well, and it is a bone conserving option, especially in young patients. However, in some of the arthritic patients, especially with severe deformities, the PCL may be defunct. Sometimes if the slope of the tibial component is not appropriately addressed, the tibial insertion can be sacrificed when we are resecting the tibial platform. You can have around 8 to 10 degrees less flexion as compared to a PS design that has been shown in the literature. It could be difficult to balance, especially in deformed situations. The kinematic conflict has been talked about because of the conformity and the posterior rollback. And sometimes in the kinematic studies, it has actually been shown to have paradoxical anterior roll forward because of the absence of ACL. Now, Cochrane review has suggested that using a dished insert or a congruent insert with or without PCL has no difference with respect to the functional outcome of the patients. When we looked at the clinical outcomes and usage, more than 65% of total knees performed today still continue to be the PCL retaining design across the world. And this is from the registry data from UK and Australia. They have been shown to have lower revision rates as compared to more constrained designs, and 96% survivorship at 10 years with the modern cruciate retaining implants. When we look at the kinematics, we discuss the paradoxical anterior roll forward, especially of the medial femoral condyle, which can give rise to the sense of instability for the patient. The consistent posterior rollback is lacking when the kinematic data have been evaluated, and lesser flexion has been reported with the PCL retaining knees as compared to the PCL sacrificing or the PS designs. Now, if you look at the figure here, you can see here that the femur is articulating more posteriorly. That indicates that the PCL is tight, and these two parameters must be looked at where the femoral condyle is articulating on the polyethylene. Typically, we want it to articulate in the middle third of the poly, not anteriorly, which indicates it's too loose, or too posteriorly, which indicates it is too tight. And we do what is called as the lift off and the pull out test with the PCL retaining knees in order to balance the PCL. If the tibial base plate or the poly is lifting off or the femoral component is pulling out, that means the PCL is too tight. And if there is too much of anterior translation, then that means that the PCL is too lax. The important tips for surgery are that the posterior tibial slope must be between 3 and 7 degrees. It should not be too much because it will compromise the PCL, or too little because it will make it too tight. The femoral component sizing must be taken care of. The PCL retaining knees are very sensitive to joint line elevation, so less than 2 millimeters of joint line elevation is tolerated. Severe preoperative deformity sometimes requires sacrifice of the PCL in order to get the good result. So you can see this video here that the PCL is tight, and you can recess the PCL and you can see that the posterior articulation has just moved back and the femur is now articulating in the central third of the implant. And whenever we recess the PCL, we tend to use a more nowadays, which is the curved plus type of insert, where the posterior part of the thing remains similar to a cruciate retaining insert, but there is a slight anterior elevation which improves the stability when we have recessed the PCL. Coming to the posterior stabilized knee replacement, here the PCL function is substituted by a cam and post mechanism, the metallic cam on the femoral component and a post on the tibia. And you have varying designs of this cam post mechanism and the location of the post, which have been manipulated to optimize the femoral rollback. Kinematic studies have shown that there is bicondylar rollback of around 7 to 8 millimeters in the PS designs because of the engagement of the cam on the post. And this box height ratio, that is the diameter of the box to the total anteroposterior diameter of the femoral component, is an important criteria while choosing the posterior stabilized inserts, posterior stabilized components. So this is an example where there is a posteriorly based box with a favorable box height ratio. But if you have a box height ratio of more than 0.7, then that predisposes to patellofemoral complications. The advantages with posterior stabilized implant are that it is more predictable for correction of severe deformities. There is a predictable bicondylar femoral rollback due to engagement of cam and post. The femoral flexion tends to be better due to improved kinematics and balancing, and it is slightly more tolerant to joint line elevation as compared to the PCR designs. However, because of the unpredictable increase in flexion gap on resection of PCL, there is a tendency towards flexion instability. And if the joint line is elevated too much because of balancing of flexion extension gap issues, then there could be issues of mid-flexion instability as well. There is risk of bone loss due to box removal. There is increased risk of patellar clunk, especially with box height ratio more than 0.7, and higher risk of periprosthetic fractures in smaller sized implants. Now, the medial pivot design is not a new design, and it was actually designed way back in the 1970s. And it constitutes of a single radius curvature femoral component with a variably shaped polyethylene insert, which tends to be more congruent on the medial side and slightly less congruent on the lateral side. And it comes both with a cruciate retaining as well as a cruciate sacrificing design. And this design rationale is based out of studies of cadaver and living knees, which showed that there is femoral external rotation with flexion, femoral posterior translation with flexion, which was more on the lateral side. And therefore, the normal knees were tending to have a medial pivot type of motion. And this led to the development of this particular implant design. However, none of these studies observe walking or running, and there are more studies which have come out on the knee kinematics in walking and running situations. Now, in vivo kinematic analysis, the Comistech paper, which was quoted previously, has proved the medial pivot concept. And it has been shown in several studies that the knee tends to be a medial pivot with very little movement on the medial side, around 2 to 3 millimeter, but around 19 millimeter of movement on the lateral side owing to the specific anatomical considerations of the femoral condyles. Now, the clinical evidence behind this concept needs to be validated. Will there be kinematic conflict, limited range of motion, patellofemoral complications, early wear? And will a pattern of motion similar to healthy knees be ideal for prostheses implanted in knees that might have lost the cruciate ligaments? And what about the clinical results as compared to the conventional non-conforming knees?
Please conclude.
In patients, it has been shown that the kneeling is safe with the medial pivot design. There are significantly less patellofemoral complications, and the polyethylene wear particles tended to be favorable with the medial pivot knee. And this showed that there was no kinematic conflict, patellofemoral complications were favorable, and there was less risk of wear with the medial pivot designs. And the long-term results have borne out this particular concept. The latest research has, however, shown that healthy knees show different patterns of motion depending upon the activity. Squatting, kneeling, and lunge type of motion most often show a medial pivot pattern. Walking, running, and pivoting type of motion near extension most often show a lateral pivot pattern. And posterior femoral rollback and external rotation of femur in flexion are constant. And therefore, a knee which has got lateral pivoting motion in extension and medial pivoting in flexion is the one probably which makes more sense. Thank you very much.
Thank you, Kiran, for an excellent talk on all this three different aspects of the joint. Can we invite Dr. Mohanty, our ex-president of IAA, is going to give us the talk on various constraints in primary total knee arthroplasty. Subhranshu.
Thanks, Asit, for the opportunity. Thank you, Rajiv, for this opportunity as well. So I'll be talking about different insert types in the total knee replacement, and I'll go very basic about it, considering what we have decided during our discussion. So if you see the a normal knee, normal knee, there are two collaterals, two cruciates, and two menisci, and there are three compartments: medial femorotibial, lateral femorotibial, and patellofemoral compartments. Now, what is the role of PCL? What is femoral rollback? Many people don't. Many of our residents don't understand what is rollback mechanism. Imagine femur is a ball and tibia is a flat surface, and when you flex the knee, the ball rolls on the flat surface. So when you flex the knee, gradually what happens? The ball rolls in the flat surface, unless what happens in a deep flexion, when you go to more degrees of flexion, gradually this ball will roll on the flat surface and it may come out of this flat surface, that will knee may dislocate. So in order to prevent that dislocation, the nature has kept what is known as posterior cruciate ligament, which pulls the femur back so that it doesn't dislocate. So in addition to the rolling mechanism, there is a gliding mechanism, and this PCL, it glides or pulls the femur back so that it doesn't dislocate. That is known as femoral rollback mechanism, which is an important function done by the posterior cruciate ligament. So whenever posterior cruciate ligament, if you are sacrificing, then you should have some mechanism which will do this work, and that is done by the cam and post mechanism, or deep disc insert like a anterostabilized knee, that we will discuss in the later part of my lecture. Now, if you see the classification of the knee, depending upon the compartments replaced, it is either unicompartmental, bicompartmental, or tricompartmental. So unicompartmental knee, when you replace one compartment of the knee, that is either a medial compartment or a lateral compartment or a patellofemoral compartment. Nowadays, patellofemoral joint arthroplasty, which is available. So bicompartmental means when you replace the medial and lateral, femorotibial compartment, or this knee has failed in the history. Chanley has designed this kind of knees earlier part in his career. And of course, nowadays, these are bicompartmental knees which are available in the market, where you replace the medial compartment as well as the patellofemoral components. For all practical purposes, the bicompartmental knees are this kind of knees. Now, most of us, what we do tri-compartmental, knee replacement, where you replace all three compartments. when you replace all the three compartments, that can be divided into unconstrained, semi-constrained, or fully constrained, depending upon the ligaments. As you know, there are two collaterals and two cruciates. Most of the time, anterocruciate ligament is either degenerated, or you sacrifice the anterocruciate ligament during knee replacement surgery when you do a total knee replacement surgery. So unconstrained knee, basically it's a theoretical term where you keep both the collaterals and both the cruciates intact, where you do basically in a unicompartmental knee or a bicompartmental knee. Whereas sometimes in some literature you will find that cruciate retaining implant has been termed as unconstrained knee. Don't get confused. So unconstrained knee, sometimes in some literature you'll find cruciate retaining or unconstrained knee they have described. Next is semi-constrained knee, which is commonly all over the world the commonest knee which is practiced, where you basically sacrifice the anterocruciate ligament and depend the stability depend on the collaterals for the knee stability. Whether you keep the posterior cruciate or sacrifice the posterior cruciate, that will come to later. That is all included in the semi-constrained knee. Whereas fully constrained knee, where the collaterals are deficient or the knee stability doesn't depend on the collaterals, you have to have some kind of hinge knee or something like that in order to have a fully constrained knee. So semi-constrained knee, let us focus on a semi-constrained knee, which is classified into three varieties, which is posterior cruciate sacrificing. That means you are sacrificing both ACL and PCL, but you are not replacing with any kind of mechanism. Those are the knee or total condylar knee, which is earlier there. Now it has gone out of the market. An excellent knee, which did well, but unfortunately, because of lack of more range of movements, these knees went out of went into disrepute. So nowadays nobody is using total condylar knee, though it has got a good long-term outcome. Whereas posterior cruciate retaining means you are keeping the posterior cruciate ligament, and all the CR knees are posterior cruciate retaining knees. And finally, the posterior cruciate substituting means you are sacrificing the posterior cruciate ligament, and then you are substituting it some kind of mechanism like a post and cam mechanism or a deep disc or what is anterior stabilized or ultra congruent knee that I will describe a little bit later. And finally, as I told you, fully constrained means all the collaterals are gone and there is severe bone loss, marked ligament laxity, especially when you excise the tumors and revision procedures, then you do this kind of knees. This is one kind of, Coach femorotibial reconstruction in a tumor resection, or you can use endolink kind of knee, which is the hinge knee where, there's a collateral is deficient. Now, the first is, let us discuss about the cruciate retaining knee. When you are starting your knee replacement surgery, ideally, if you are doing a posterior cruciate retaining knees, then your selection of the patient should be like this. If there less of a deformity like fixed flexion deformity less than 30 degrees, varus and valgus deformity less than 20 to 25 degrees. If there is joint subluxation, less of joint of subluxation, and structurally intact posterior cruciate ligament. And as Krishna told you, that is technical ability of the surgeon is important. And now most of the surgeons are probably moving towards cruciate retaining the, and they are technically, you have to be more competent in order to balance that posterior cruciate ligament or release some fibers posterior cruciate ligament when you have a more deformed knee. And some of these surgeons also, they have shown in the literature, they use posterior cruciate retaining knees in the revision of a unicondylar knee sometimes. And probably that is to preserve the bone. So these are the indications of cruciate retaining knee, but many surgeons who are experienced, they use cruciate retaining knee in almost in every knees, whether it is grossly deformed or gross, severe flexion deformity as well. Now, the main controversy of cruciate retaining, cruciate sacrificing knee, that you have a more box cut in cruciate sacrificing compared to the cruciate retaining knees, as Krishna also told you about the ratio. And that is why that in posterior cruciate stabilizing knee or PS knees, that you take out more of bone, and which will be detrimental for a revision situation. So cruciate retaining, the advantage that there is improved stability, this is reduced shear stresses and improved proprioception because of posterior cruciate retaining knees. And there's efficient gait patterns during level walking or while stair climbing. And it preserves the femoral rollback, which improves the extensor efficiency, improves the range of movement by minimal impingement of the femur under tibia, which reduces the loosening and excessive polyethylene wear. And all the comparison of the literature, what has been shown between cruciate retaining and posterior stabilizing or cruciate sacrificing knee is that most important thing that patients while getting up from the chair or while descending from the stair, during these two times there it is more more of a natural phenomenon when you are retaining the posterior cruciate ligament, which is little the patient feel little discomfort while doing these two activities. So these are the two important activities which are more natural when you are retaining posterior cruciate ligament. And the registry data, if you see, National Joint Registry of the England shows out of the nearly 60% are cemented cruciate retaining knees and fixed bearing knees, and 20 to 21% they are posterior cruciate sacrificing knee. Out of all the cemented knees, almost 66.6%, that is 2/3 are cruciate retaining knees. And Australian Orthopedics Association joint replacement surgery shows that 67%, that means more than 2/3 are almost are cruciate retaining in that what they are using. And the use of cruciate sacrificing prosthesis had declined from 2008 until 2016. And it has been shown in the registry also, cruciate sacrificing and medial pivot prosthesis has got little higher rate of revision compared to cruciate retaining knees. Now let's come to posterior cruciate stabilizing or cruciate sacrificing insert. When there is severe flexion deformity or varus valgus angulation of more than 20 degrees or joint subluxation, these kind of knees are better addressed with this posterior cruciate sacrificing knees or posterior stabilized insert. And these are the posterior stabilized inserts which are available in the market in the fixed bearing situation, in a mobile bearing situation, or you can use a all poly tibia like this. Though all poly tibia is not much used, but it has got an excellent outcome. We had shown in 2004 the study from Ranawat Center when I was doing my fellowship that even all poly tibia inserts are doing extremely well in young patients, not a single case of aseptic loosening which was seen. And it has changed the practice from 2004 onwards, and it was awarded James Serend Award by the American Academy, because previously people used to think that all poly insert is used only in old age group of patients. Now, so in this kind of deformities which we commonly seen in India, we use posterior cruciate sacrificing knees or PS knees, and that will give a good long-term outcome. And of course, the posterior cruciate stabilizing mechanism is helpful in the high flexion knees like this. You will hear about it later in the Rajiv probably is talking about high flexion knees, so that it allows the patients to do high flexion activities like sitting cross-legged. Now the main controversy is that it takes out much of the bone in the notch cut. As you can see here that this is one of the Johnson knees where you're taking out a lot of bone stock there, and which is less of course in Baumann knees, and nowadays in Persona knees you are taking up less of notch cut Persona and Athene knees. And this is a study which shows that Sigma PS knees takes out more volume of bone compared to Biomet and Persona knees, and probably Persona knees is taking out the least amount of volume of bone in the notch cut. Now, one word about deep disc, ultracongruent or anterior stabilized. Whenever in a posterior cruciate, if you are retaining, you are doing a CR knees. But suppose if you see that there is a posterior cruciate is disease or degeneration to a certain extent, you can use this kind of ultracongruent or anterior stabilized deep disc knee. Here the mechanism is again similar to the post and calm mechanism, that whenever you are flexing the knee, the anterior, this lift insert that prevents the dislocation, that means it acts like a check when anteriorly. So this is basically a ultracongruent or deep disc or anterior stabilized knee, and this is a cruciate retaining, this is a posterior cruciate sacrificing knee. So the same mechanism, so it helps in the posterior cruciate sacrificing situations. Next comes the Varus Valves constraining knee. When the posterior stabilized, it is basically a posterior stabilized design where tibial post is taller and larger with deep femoral box. It allows small movement in the coronal, AP as well as axial planes, and provides about 2 to 3 degrees of Varus Valves stability and 2 degrees of rotation. And here the tibial and femoral components are not linked, and hence there is a chances of instability if there is a big flexion gap compared to the extension gap. Now the indications, if there is more severe deformity like valgus deformity with incompetent medial collateral ligaments, severe bone defects, severe flexion contractures where you are inability to balance the knee the flexion gap with the extension gap. And if there is a varus valgus laxity of more than 5 millimeter throughout the range of movement, extra articular deformities, uncontrollable, as I told you, flexion extension imbalance, and of course certain conditions like poliomyelitis or neuropathic arthropathy, then it's preferable to use varus valgus constrained knees. Now, in this kind of situation, when there is a loose prosthesis, so you have to do a revision surgery. You can use augments and various kinds of stem extenders. You have to use varus valgus, constant prosthesis in this kind of situation. And whenever there is doing a revision surgery, especially this infected case, when there's a severe bone loss, you can reconstruct with a varus valgus, constant prosthesis using stem extender, which is more natural, compared to the hinge knees.
One thing.
Yeah, I have 2 more slides to go only. So the criteria of varus valgus constant in that flexion extension gap balance should be within 5 to 10 millimeter. Joint line restoration should be within 10 millimeter, and reproduction of the AP diameter of the femur within reasonable limit, and some degree of collateral ligament stability has to be there in order to do this varus valgus constrained knees. Finally, the hinge implants, when there is severe instability, that means the collateral ligaments are deficient, then you have to a hinge implant. It limits the varus valgus as well as anteroposterior translations. But in compared to the VVC or varus valgus constrained knees, it may allow greater rotation especially in this kind of rotating hinge knees. So finally, you have to have a proper indication, and then you have a proper implant selection. Of course, the craft or the surgical technique is important for a long-term outcome of your prosthesis. So you will do all the knee replacement as merit literature shows. First year post total joint replacement, most painful replacements are because of infection inoculated during surgery during first year, the failures. But if you're looking at 10 years, 20 years down the line, careful attention to the technique and quality of implant can make a difference between successful, symptomatic, and failed total joint replacements. Before I complete, here I take this opportunity to announce my candidature for the post of Vice President of Indian Orthopedic Association elections this year. I request all of you to support. The elections will start in September, October. And I have been the past president of Bombay Orthopedic Society and Indian Arthroplasty Association. And we can make IOA more academic organization with your blessings and support. Thank you for a patient hearing.
Thank you, Mr. Branshu.
Yeah.
Okay, so now it is my turn. Basically, can you see everyone?
We can see.
Yes, okay. Thank you very much. So I'm going to talk a little bit in different direction about modular knee, the fixed bearing implants. As we've seen that most of our knees are the modular knees. And what is a modular knee? And that is something that our junior colleagues, they need to understand. So this talk is on that. The first condylar design in 1974 was a fixed bearing design. The fixed bearing designs have stood the test of the time. It is improvement in the design and the material, as we've heard Dr. Raj Sinha, has caused further improvement in the long-term results of this fixed bearing implants. So how do we classify fixed bearing implants? They are either monoblock implants or a modular implant. Monoblock can again be subdivided into all poly or molded metal back, while modular knees are generally either CR or PS, or they can be fixed bearing and mobile bearing as well. So let us see. What is monoblock? Is basically one single piece of polyethylene which has got a design of a stem that is going to go into the keel, basically going to go into the tibia. It has got the width, as we can see here, of the tibial surface, and it can be either in a CR form because there is no post here, or it can be in the PS form. This is a monoblock knee, but where the metal back keel is there and there is a tibial tray which is compression molded with a polyethylene. So it is called monoblock because there is actually no movement happening between the poly and the tibial tray here. This is our standard modular tray where we have a tibial implant onto which the tibial insert locks and finishes our entire assembly. Molded metal back, as we can see the undersurface, there is actually a tibia metal base plate which is gone from here to here, and the polyethylene is compression molded over it. So actually there is no space between the polyethylene and the tibia. Review of literature, Australian and UK registry both show slight in favor of fixed bearing as compared to mobile bearing. However, as it happens in most of the registry data is pulled between the beginner surgeons, the experienced surgeons, the centers where there is particular knees are designed, and very occasional user. So it's like a mixed bag. So we can have a little skewed data from this, but however, we can know that fixed bearing are also doing very well in terms of this registry data. Some literature quickly: survivorship of Genesis total knee, 96% at 10 years. Anatomic graduate components, 98.8% at 15 years. Total condylar knee, 91% at 23 years. And taking revision for mechanical failure, aseptic failure as an endpoint, 20-year overall survival rate with total condylar knee was 91.9%. All poly also, as Dr. Mohanty just mentioned, 91% survivorship at 23 years from Tom Skulko, which is from HSS. And Dr. Ranawat also has mentioned the same paper that Dr. Mohanty just mentioned. Dr. Ranawat has mentioned this, that cemented fixed bearing total knees is the standard by which all others are judged. So whether it is a mobile bearing, high flexion, the gold mark, the benchmark is that of the cemented fixed bearing results. Another Asian publication again talks good about all polytibia with 96.4% of metal back and 88.4% for metal back. The 96 was for the all poly. So all poly and the metal back both work very well. So what is the controversy? In polyethylene wear, in a metal back implant, that's a modular knee, femoral component and polyethylene, the wear occurs at this particular site. And also there is a slight movement between the polyethylene and the under surface of the tibial tray, as it is called backside wear. Osteolysis and aseptic loosening and radiolucent lines at the interface. So these are the three main controversies of this. Now, where does it occur in fixed bearing knees? In a fixed bearing knee, there is anterior to posterior gliding of the femoral component, and the rotations occur of the femoral component at the upper articulation. So that is between femur and the polyethylene. While micromotion between the under surface of the polyethylene and the metal tray is responsible for the backside wear. So actually in a fixed bearing, the poly wears from both sides, from the top and from the bottom. However, there are few observations that are made. Polyethylene stress concentrates along this direction of the way the movement is happening, and this increases the resistance to polyethylene wear. Newer poly, as we heard, enriched with vitamin E or cross-linked, along with newer material and newer implant design, seem to have reduced the wear further. So though fixed bearings wear at both top and the bottom, we don't see that they fall apart within 3 years, 4 years, because there are different things that we do as a surgeon, and the most important thing is here is a surgical technique. So factors that affect the poly wear are the implant design and material, but most important thing is surgical technique and patient's level of activity. Titanium tibial tray, as we heard, there is difficulty in getting a smooth polished surface. So latest manufacturing process, however, have shown better ability to polish titanium. Cobalt chromium is highly smooth and absolutely minimal friction occurs between poly and the tray. The RA value, which is actually the indicator of surface roughness for cobalt chromium tray, is reduced by 95% as compared to titanium tibial tray. Locking mechanism, earlier designs had just a standard rim fit. However, newer I2 mechanism have got multiple locks, and even the higher version, that is the Achun and Persona, have different way of locking the poly into the fixed tibial base plate. As we can see here, how differently the locking happens. This is the tibial metal, the base tray, and this is the polyethylene, and it locks very well. This is a newer I2 mechanism. Conformity, also briefly touched upon by Dr. Mohanty, is larger the surface area contact between the femoral component and the polyethylene, lower are the contact stresses, both in neutral alignment and varus or valgus compared to flat on flat design. Higher the conformity, lesser are the stresses on the polyethylene. It means round on round is the better design. Less shear stresses on the implant bone interface and less osteolysis and subsequent implant loosening. So conformity round on round is the best, as we saw in the previous talk of constraints. Flat on flat has a very high edge loading, especially if it is drifted slightly in varus or valgus at the time of surgery. Round on flat is the worst because there is actually the point loading of the poly all throughout the range of movement, and actually poly gets dug as soon as the flexion movement starts. So the conformity is something that is very important. So in vivo data lacks to prove the superiority of the mobile bearing. Fixed bearing also has a long-term successful track record. There are multiple publications and also, as we've seen, the registry data. Recent improvements in designs of the implants material have significantly reduced the wear and osteolysis. But apart from all this, surgical technique is of paramount importance because balancing of knees is very important. As we see here, these are my personal studies, and these are all 10 years post-op. Most of them are all poly. One of them is fixed bearing, and they all are doing extremely well without any problems. These are the modular implants, which have also stood the test of time. So in conclusion, fixed bearing implants are here to stay. They are recommended for beginner arthroplasty surgeon because you don't have a major complication of bearing spin out, which can be a fear in a beginner arthroplasty surgeon's mind. However, for an experienced arthroplasty surgeon, it is a personal choice of what they want to use and which particular implant or for which particular patient they want to use that. So thank you very much for your attention. Can I now invite Dr. Rakesh Rajput to have completely 180-degree different view? Rakesh, on a mobile bearing. He's going to talk on mobile bearing.
So thank you, Ashit, and thank you, IA, for giving me the opportunity. So Ashit, you showed very eloquently on the fixed bearing, and then very nicely, a few days ago, you asked me to speak on mobile bearing. So I think let's go to the history of mainly about the fixed bearing. And you realize that we had a very good successful TKR outcomes. But two important issues always were troubling us. One was the loosening and the other was wear. And the moment you look at the long-term failures, these two actually became the principal reasons for failures. So why does things loosen? If you have too much of forces acting on your poly, and if the poly is actually stuck to the base plate, then the whole forces are transmitted to the base plate and the bone interface, and no wonder that it actually causes loosening. Now, if you don't have too much of congruency, then what happens is there is poly which is running around everywhere, and the implant, the femoral surface, which is the articulating surface, is running around everywhere and causing amok. So you have what we call as a polythene wear. So from history, if you want to tackle these two issues, how do we do about it? So we want conformity because you want the forces, and all the speakers before me have been harping about this issue, that you want congruency between the femoral condyle and the poly, which I think Asit mentioned about as a round articulation. But what is that doing? It is increasing the stress on the implant and the bone interface. So how do we reduce that? If we can somehow make this poly move, then maybe we can transmit less forces on the bone. And that's the whole concept of mobile bearing. And also you should realize that we want our implants to last longer. We have patients which are putting more stress on their bones. We have a typical patients of 50-year-olds or in 50s. In India, it's getting very, very famous now. And they are expecting 30, 35 years of function from their knees, not only just function, but very active functions. And, when we talk about joint replacement, whether for hip or knee, we normally give 1 to 1.5 million cycles per year. But that's not going to be enough for these people. Some of these younger guys are actually putting up 6 million cycles per year. So naturally, we need to think about poly wear a bit more seriously in this younger group of patients. So what we have just discussed is a kinematic conflict. So you want low stress, but you want full congruency. And the fixed bearing actually has reached a limit for these two articulations. So by definition, if you want to say what is mobile bearing, so you will have a poly which moves around with a femoral component. It could glide from front to back, it could move side to side, or it could just rotate. So you can have different versions of what we call as a mobile bearing. And the reason you want that is to avoid these sort of failures which you see. And if you look at the poly, this is not the type of things you want to see on a poly. You want these polys to last longer and longer. And the two things which we can do that is, one, make a very good poly, which will come probably from the materials which are getting better. And the second one is to actually make this thing move and get away from having too much of stress. So we've just discussed the fixed bearing disadvantages. So I'll look at the advantage of mobile bearing. We've realized that it is more conforming. We have realized that it will distribute more stresses. But how it does is by actually self-correction. So the moment the femur is moving somewhere else, the poly moves with that. And that's how it's doing self-correction. So that's what we think that might work with that. So are there any disadvantages by doing this? And the answer is yes. If you look at the previous generations of LCS, and that's the number one mobile bearing knees we had in the market a few years ago, and we learned things from that. And one was the bearing spin out, which means the poly actually rotated too much and went behind the femur, or the poly frankly dislocated. And that happened also in many cases where the poly was not restrained. And even some of the UCAD designs, like in Oxford knee replacement, we found occasionally the poly used to dislocate. And again, design changes happen there. Now, also, if these things are going to happen, these are going to happen very early in the patient's tenure. That is why the first year revision rates for these early mobile bearings were much higher. And we needed to do something about the complications which were arising from that. No wonder initially these implants were a bit expensive, but now I think that's not the issue anymore. But as pointed out by both Ashit and also by Raj, that if you look at the registry data or if you look at the papers, there isn't a very significant difference between fixed bearing, mobile bearing, fixed bearing, high flex, not flex. All of the knees are actually done very well nowadays, and they're all doing very good results. So there is not a lot to gain for a box standard thing by converting them into a mobile bearing. And the other issues we were trying to solve is the J-shaped curve, which we've been talking about. I think even Krishna mentioned about different curvatures for the knee. And for a fixed bearing to match all these different curvatures by whichever way, whether you have a single radius or multi-radius or a very typically J-shaped radius, these are not still able to match because the bone resection which you're going to have, you do not know how much you're cutting. Sometimes you are cutting 2 mm higher, and then the whole curvature changes. So even the fixed bearing single radii knee fails if you have not cut the actual distal femur in the right way. So this is what we've been telling so far, that when the knee starts bending, you have the femoral femur which comes actually backwards. And then if you see on the right side of your diagram, there is a pinpoint loading on the back side. So unless the poly also has moved or rotated along with this condyle, the point loading is going to happen. And that is why the whole essence of talking about the mobile bearing. And if you look very carefully about this biomechanics system, so you have anterior, look at the posterior, lateral, and medial. So the red line is when you are starting in a full extension. And what is meaning is the medial and lateral condyle of femur. So imagine your lateral and medial condyle of femur. On the medial side, it hardly moves anywhere. And that is what Krishna also showed you in biomechanics. But if you see on the lateral side, in a normal circumstances, when even the ACL is functioning, you could have 19 mm of movements around there. So you're basically rotating all the way backwards as you are flexing more and more. So this is what we are trying to see if we can replicate by mobile bearing knee. So you principally require rotation. If you see the points, they haven't really moved a lot. So by actually making the whole poly move front and back is not that desirable, but it needs to rotate, and that is desirable. Also, you heard, I think, Shubhranshu talking about that. There are occasional mismatches we have between the base plate and the actual cut tibial surface. So you want to put the cut tibial surfaces and the base plate with congruency, but then the poly will have to take some other way in which the femur is moving. So then that's some small amount of freedom which you need will be given to you by the mobile bearing. And this is how the mobile bearing actually moves. So it gives you that amount of freedom which you were apprehensive about. Now, if you look at the lab data, clinical data we know hasn't really shown very much because we are not looking at a very long-term survival. Most of the studies are looking at 10 years, 15 years survival. But if you look at the lab data, which can replicate a long-term survival, you can clearly see that the fixed bearing is 4 times higher wear rate compared to a rotating platform or a mobile bearing knee. So that is a clear difference in a lab data. And I'm sure that if things are done properly, the lab data should actually replicate even the clinical data. So I've just mentioned about the 2 types of mobile bearing. One is just rotation and the other is anteroposterior and side-to-head rotations also. So mobile bearing, the advantages we have spoken about are the lower polythene wear, lower fixation stresses, more forgiving to malrotations, less load to constraining mechanism, and ability to self-align and better fixation and mechanisms. Now, if you can combine these things with certain other things we desire, like high flexion, and if you can also have not too much of making in the notch, because most of the mobile bearings will actually come with PCL sacrificing. So if you are not cutting too much of the notch. If we want high flexion and we still have the mobile bearing, I think that would be the game changer. And the LCS surgeons have now moved forward and taken those drawbacks and actually design a newer knee, which gives you all these 3 components. So I'll just show you briefly how this knee actually works. So that is a tibial cut, which is actually one of the most crucial cuts in this knee. And then you go around preparing your femur first. And the first cut you really want to do is getting a flexion gap. So you make an entry into femoral canal, and that's just the entry going into the femoral canal. And that's all very guided, by the way. It's not very random way. So now you attach what we say as the flexion gap jig. This is a very constrained jig which goes in. And then you start putting the jig in and get your flexion. So first thing you get very right is your flexion gap. And you make sure that the smallest amount of jig which is required, which because the more bigger you have flexion gap, the same amount of extension, you'll have to cut more bone and femur. So get the smallest amount of spaces in and then balance it both ways. Now you see that your femur, the cutting block of this femur actually already has balanced the rotation based on your jig. So now you have the anterior cut, you have the posterior cut, which are all based on the jig on which the tibia was actually cut. So your tibial cut is very, very important here. Based on that, you've cut the anterior cut, you've cut the posterior cut. So you've got your cut right. You've also, now once you've done that, you put the spacer block in and then just check whether you are happy with this cut or not, because this is where you're starting to actually start balancing. So once you're sure that the balance is good, now you want to match your extension gap to your flexion gap. So this is the extension jig which is going in. So you fix with 2 pins, and then you again just start checking with the same spacer which you had used for the flexion gap, that are you happy with this extension gap? The good point of this system is that you can move these pins forward and backwards, and that will, if you have like loose, you can bring the pin distal, and if you are tight, you can move the pin forwards. Once you've got that, now you're ready to cut, and you're going to get a good balance on your extension gap also. You again check with the spacer, and once you are happy that your flexion and extension gap were well balanced, you can then decide to start, implantations. The good thing about this tibial preparation, there's only one keyhole which goes, and the keyhole will be slightly bigger, just like a attuned knee, because you need to have the rotation which will happen in that, which is a big poly pipe, because you don't want the poly to jump. So it will be a longer hole and it will be a bigger hole because the whole rotation is going to happen on the poly. And you have a freedom here. You can match this tibial tray based on the tibia, because the poly will move along with the femur. So in our case, this demonstration, we had a slight weakness of the, we didn't have a very good tibial surface. It was a bit rheumatoid patient. So actually in this case, we have put a stem also. And this insert is very highly congruent. That is where you see the lips on the posterior side are very high up. There is this anterior stabilization which we've been talking about. So you need to use a bit of force to get this poly in first. And that's why you need to first put extension, come back into flexion. Then you have your poly well inserted. And this is almost like a capture mechanism type of mobile bearing knee. Then you start cementing, you start putting your femur. Initially, the femur has to go in full flexion. So once you have almost the femur going in, we first put our hand forces, and then we start straightening the knee. Then we come to around 90 degree, and the final implantation of the femur happens in about 90 degree of flexion. And this knee, also the advantage is it also comes in ported versions, like I think Raj spoke about the trinitrate. So we have what we call as a golden knees in these ones, and you can get a very good balance with these ones. Both tracking is very good. Your flexion balance is very good. So in all essence, with just one design, you get actually everything you want, which you're asking for current day and age. And these are some of the examples of doing this mobile bearing knees, along with this is ultra congruent and also very high flex. So there are some of the examples of all these knees, and we can go on showing the extras. But I think in the end, what you're looking for is a well balanced knee, which is giving you equal flexion and extension gaps, which is giving you the least amount of femoral cut you want to do. And for that, I think this is a wonderful way of doing mobile bearing knees. So friends, what I want to say is it's the balance you want to achieve. So not all cases will be good for a mobile bearing, but there will be certainly some cases which are excellently done by a mobile bearing knee. Thank you.
Thank you, Rakesh. Thank you very much. That was an excellent demonstration, surgical demonstration. And so can we move on to our last talk of the day? Dr. Rajiv Sharma is going to talk to us about the high flexion knees, achieving high flexion in primary total knees. Rajiv?
can make slideshow now.
Slideshow, yeah. Bottom. Yeah. Bottom of the screen.
Let me unmute myself first.
Yeah.
Sorry, it was a. Can you see the screen, please?
Yes. Very well.
Okay, friends. Thanks, Ashit. I think it has been a wonderful discussions about the various designs and how the surgical technique is right. I'll restrict myself as the last talk of the day to how to some clinical aspects and some aspects about the high flexion implants. Achieving high flexion is important, but what is important is a good total knee should have painless range of movements and maximum range of movement as you can achieve in that particular patient. What is important is that you have a balanced soft tissues, you make the correct bone cuts, good wound healing, which is very important. And when you have all these things, you will have around 80 to 85% patients who will have the excellent satisfaction. What is important in the knee is a normal knee, as you see here, is not moving into the one radius. And that's what we discussed in all the previous talks, that the knee joint radius is moving as the range of motion increases. And what is important is that we have to be sure that the infection is the first killer for the range of movement or the surgery. And second is the instability. That's what we have been discussing in all the previous talks as well. Now, high flexion is achieved by a well-balanced flexion extension gap, correct rotation of the femoral component, good patellar tracking, choosing the right size of the femoral component, no stuffing of the patellofemoral joint, and maintaining the posterior offset. And all these things together, once you achieve, you have a high flexion. And just a few examples of these are our cases. You see the PFC Sigma, one of the very old design. And you see the high flexion is possible even in this. But you see in the last stages, when the joint goes in flexion, the poly goes away from it. What you have in the present day designs, then you see the mobile bearing joint. You see that the flexion happens, but in the terminal stages of the flexion, it is not, the joint is not able to, femoral component is not covering sufficiently. Now, in this design, which is an older design of the PFC RPF, you see that the high flexion was possible, but the problem was that this design was taking away too much of the posterior femur. My suggestion is that if we follow all the pre-operative, per-operative, and post-operative protocols, especially the per-operative, if we discuss the adequate exposure, bone cuts, posterior offset, stable joint, and a balanced patellofemoral joint. And we'll just discuss in brief about it as a last talk. We'll try to finish it up as early as possible. Bone cuts and alignment is very important. Transepicondylar line, you must always place, because that will give you a good assessment. And if you see here that the inflection, you have an excellent balance of the joint. What is important is that posterior offset should be maintained, and posterior clearance is very important. If you use this kind of a distractor, it makes it very easy to have a good clearance posteriorly. Stable joint and a judicious release. Not that every patient needs too much of release. Do the judicious release as much as required. And that judicious release, if you do, in some patients who have a little bit of tightness of the MCL, do the release as much. And in certain patients, you will need more release. What is important is that stable joint and not too stuffy joint. If you make a very small tibial cut, that is not right. If you make the extension gap very tight, you will have a flexion deformity. So the stability is very important, and the MCL tension is very important. You should have the tension of the MCL as much as required. Not too much and not a loose MCL. And if needed, you can do the corrections even without the navigation in a very easy way. Change the position of the pins, change the position, they shift the AP cut box, AP cut instrument anteriorly or posteriorly. And when you do this, you see that in one patient, where you see that the transepicondylar line is not parallel to the posterior part of the of the implant. While it is important that this should be the way that the epicondylar line and the femoral component should be parallel, and these two should be parallel to the tibial cut. Flexion gap laterally that you see here, but it can be balanced, what you see very easily by shifting the epi cutting jig. Balanced patellofemoral joint is very important, because without this, you will have an internal rotation of the tibial component, and the rotational mismatch that is possible in 16% of the cases or more is one of the very important reason why you may not be able to achieve a good flexion, though on the X-ray the implant may be looking good. So patellofemoral joint is very important. You should choose the right size of the femoral component so that it is not stuffing anteriorly. You do the correct lateral rotation of the femoral implant. You have the good patellar tracking and correct thickness of the patella if the patella is resurfaced. Easy flexion, that's what you see here. The patella is fitting well, and the implants, the design of the implant is also very important. That what is the design of the trochlea in that particular femoral component is very important. And if you have a right kind of the implant, and if you have the right kind of the stable joint, in my surgeries, I try to see that the Mcl tension is correct. It is not too tight, it is not too loose. And if that is so, then the spacer block itself decides that yes, we have cut the right bony cuts. The joint level is very important, especially in the revision cases. One finger breadth above the fibula, 30 millimeter below the middle epicondylar line, 25 millimeter below the lateral epicondylar line is one of the simple numbers that you should remember. Good cementing, as has been explained very well, is very important, because if there is no good cementing, you will have a rocking implants, and that will not give you a good function. Skin closure inflection. Now, my suggestion is that make the incision and suture the skin, the wound inflection. That makes it very easy to flex. Pain management is very important. If there is no pain management, good pain management, it will be a problem. And once you follow all these principles that we discuss here in my talk and in the earlier talks, you will have the easy and good function. That's what you see. Another patient, even in the revision cases. And what is important is that we should not try to look for the high flexion in unrealistic situations, like the heavy patients, the patients who had the fixed flexion deformities earlier, or who had the massive deformities. These are the patients where we should not be looking for the extreme flexion or the full flexion of the knee after the surgery. Thank you so much, Ashit.
Thank you very much, Rajiv. And that brings us to the end of all the talks. And well done, everyone. You know, it was very, very nice to know about all these implants. So do we have any questions to ask? You know, all the faculty is there. Anyone in the chat box? There is nothing.
Asit, I have a question for you, actually.
Okay.
Something you mentioned and something Raj mentioned were very much diametrically opposite. I'll just take one by one. So you said vitamin E poly has lowered the rates for wear in the joint, whereas Raj mentioned that it has not yet shown convincingly. So what message do we give to our juniors?
Okay, so what is basically I meant in that particular slide was that apart from standard poly, there are different things that can be done to increase the life of the poly. Number one is the cross-linking, and number two is enriching the poly with vitamin E. However, when we talk about cross-linking the poly, we have to have a moderately cross-linked poly, so as to have a good property of the polyethylene, so that it does not wear out. Now there are experiments where if it's highly cross-linked poly to moderately cross-linked polys have done very well. Vitamin E still is an experimental thing, so it can work either in our favor or it may not show any difference. So that is what I meant by that slide.
Okay, because Seth Greenwald recently published a whole with I think 25 authors showing now it has shown to reduce wear even in knees. Before it had shown reduction of wear in hips, but now it has shown wear reduction even in knees. So that is why I was a bit surprised when Raj, though he does a lot of this thing, he didn't mention that or he didn't agree with that. The second one was the tray. So in his talk, I think he mentioned only about titanium trays, and COCR probably is not showing anything there. But you were quite sure that COCR trays also work very well with this. So where do we stand with that one?
Yeah, and particularly, obviously, the problem with the titanium trays are, the RA ratio, that's the surface roughness between the metal and the poly is quite high when you use the titanium. And manufacturing wise, it was difficult to polish the titanium initially. And that's why cobalt chromium came in application and in clinical use. Cobalt chrome is highly, polished surface. So there is hardly any wear that is happening between the poly and the polished cobalt chromium tray. Newer locking mechanisms and this polished surface of the tibial implant has reduced the chances of backside wear. Raj, do you have any comments?
Sure, I do. Thank you. So let me address the second issue first. So the cobalt chrome versus titanium. If you're doing a mobile bearing total knee, you have to have cobalt chrome because of the RA issue.
Correct.
Otherwise, there's too much backside wear. If you're doing a modern total knee, high flex or not high flex, with a really robust tibial locking mechanism, then there is no micromotion or very little micromotion to the point where osteolysis and polyethylene wear are not too much of a problem. Therefore, titanium has become much more popular for most manufacturers, for most systems, because it's less expensive and it's less expensive to manufacture. So that's just a real world issue that we're facing. But if you're doing mobile bearing, you have to have cobalt chrome. There's no other option at this point. The issue with the vitamin E is, again, it has to do with manufacturing more than anything else. At this point, we're not seeing in vivo any significant difference. There is some reduced wear, but there's a newer concept in North American literature called minimally clinically significant difference. And so to get enough wear reduction to show improved longevity and improved function, you'd have to see so much wear reduction that all of the polyethylenes currently are in the same ballpark, so it doesn't make that much of a difference. That was the point that I was making. Having said that, the manufacturing techniques for vitamin E infused poly or vitamin E cross-linked poly have become so inexpensive that there are many manufacturers in North America that only offer vitamin E. They don't even offer the conventional poly or even the highly cross-linked. They just say, there's no downside to vitamin E. It's cheaper for us to manufacture one type of poly. Everybody gets vitamin E. So that's what we're seeing in North America.
Thank you, Raj.
That's very right. That settles the thing. Have it available. Why not use it?
I said just one more thing. So when you were talking about round on flat, and flat on flat, you mentioned the worst articulation being round on flat. Correct?
Correct.
But one of the best knees which has given longevity has been AJC, which is round on flat. So yes. How do we account for that? I mean, that was the first knee which was publishing 20 years results.
Correct. Yeah. I think
AJC has been poly has been fixed to the tray, tibial tray.
Correct. It's a monoblock. It's a molded. I mentioned in my talk there were a couple of pictures that you saw. It is a compression molded poly on the metal tray. So there is hardly any backside wear. So the issues of the backside wear are completely lost because they are not there because it's a monoblock, right? So
it's a compression. It's a direct compression molded
monopoly. Yeah, it's called DCM poly. Yeah.
With ARCOM, which was a early form of achieving moderate cross-linking before we knew cross-linking was important. So that's why the AGC is the outlier in terms of results with a.
So having said, all
would
this
consider the design is a flawed design characteristic.
So I think so. The bottom line is the surgical technique. whichever implant, whether I use PS, because even I use fixed bearing, mobile bearing, I use all poly, I use even medial pivot at times, cruciate, retaining PS, everything I use. But the important thing is to have the right selection of the patient and to execute the surgical technique. That's very, very important. So that whether it is fixed bearing, mobile bearing, high flexion, the results and everything, they are quite good. It depends on surgical technique. And that's the point Subhranshu mentioned, that it's ultimately the craft of the surgeon that will matter.
Yeah, but not everybody will be Subhranshu, you see. So we got to give something to younger guys also. Raj, just one more question.
Yeah.
You mentioned about.
Okay.
Sorry, Subhranshu, you want to ask first?
No, I wanted to ask Rajiv. Most of the high flex knees have gone out of the market. If you see, even that if you do a good job, probably in your fixed bearing routine conventional knees, you will get a good flexion, almost full flexion. Then why then are we now talking about the high flex knees, and why did it went out of the market?
I think that high flexion is not dependent only on the implant, but those certain things like for me, probably the one, as you mentioned, also the surgical technique. And in the design, if we say, and I hope that Raj agrees with me here, that the trochlear design of the femoral component is important in achieving the high flexion. The most designs like the PFC, RPF is probably no more. At least in India, it is no more now. I don't know about US if it is still being used. It was cutting too much of posterior femur, okay. So that's why it was taken off, I think.
Especially in small, size, small Indian.
In our population profile, yes, correct.
Definitely. And the box was, for the Indian patients, the box cut was so much bone resection. Yeah. Too much. I mean, it compromised the integrity of the medial femoral condyle and increased fracture risk, as far as I saw.
Correct.
So, Subhranshu, I would counter your question by saying that actually all designs now are high flex without talking about that they are high flex. By definition, you are getting everything high flex now, actually.
But one thing, Rakesh, I say here, that if you look at the longevity of the implant, in the deep flexion, a patient who has the deep flexion 140 degree, 135 degree plus, that patient in the terminal degrees of flexion, if the poly is not in touch with the femoral component, probably the wear will be more. I think where the
very true, very true.
Will be important.
So if somebody flexes that much, we should be worried about it actually.
What we are seeing with the modern designs with that degree of flexion is the posterior lip of the poly is deforming, but it's not fracturing because of the newer manufacturing techniques and the cross-linking. So you don't get the catastrophic wear and the catastrophic failure with the high flexion. So that's good. The thing to worry about, and most of the designs have tried to accomplish this, is the thing to worry about is in the early non-flex designs, when we achieved high flexion, which we did, the femoral component necessarily had to ride off of the posterior aspect of the polyethylene. So it was completely off. And the only way it could do that was to deform the poly. But before cross-linking was popular, that poly would wear and fracture. And so, that was, I think, the biggest improvement in terms of the poly and the high flex concept was making sure that the femoral component does not ride off of the tibial component. So I think Rakesh said it, all designs now basically are giving you the high flex components without talking about high flexion. But a lot of it has to do with just the fact that we're trying to make sure that we maintain congruity and contact and don't lose contact.
So Raj, just one more question, because you spoke about the manufacturing process. So you said that both the zirconium and the nitrates are very good for, and you use them when your allergy is an issue. At least the marketing bit of that is also being that they are good for younger people to last longer. The wear rates are also less. So is there no appreciable wear rate reduction, or should we not speak about it? Both for zirconium and titanium.
Yeah,
that's
so
another thing they talk about.
Yeah, so zirconium now has 20-year track record, at least 20-year reports. And again, the wear rate with the zirconium compared to conventional poly and to crosslink poly is the same as with cobalt chrome. So we're not seeing that there's a huge advantage to the zirconium. Is there a disadvantage? No, I don't think so. Same thing with the nitride titanium. I don't think there's a disadvantage to it, but there's not necessarily an advantage to it. So then the question boils down to availability, cost, patient desirability, all those sorts of things. And in North America, there's still a lot of discussion about, is allergy even a real thing? Is metal allergy even a real thing? Does the zirconium and the nitride titanium eliminate the risk of allergy? And the answer is not in everybody, because we've seen people who are allergic to cement, we've seen people who are allergic to titanium. What do you do in those circumstances? You have to go to some alternative material. So I think to answer your question, there's no disadvantage to it. I don't think there's going to be a long-term advantage to it. I think the polyethylene is really the secret sauce in that equation.
And in US, do you have any ceramic knees?
We, not routinely. You can get them on a compassionate use basis from Japan. I think Kyocera has one. That's an all ceramic knee.
Do you see that this ceramic joints will become popular with time?
Do I see which joints?
The ceramic.
Ceramic. The advantage to ceramic, in my opinion, is the cost for the manufacturers. If they can get it down to where it's less expensive than doing the metal, then it will gain popularity. I think the discussion about the advantage of ceramic on polyethylene and its role in reducing wear will become less and less of a discussion. So I'm not sure that ceramic is going to make that big of a jump. I have a question for all of you surgeons, though. Are you seeing a lot of discussion about kinematic alignment in your total knees from your patients? Are they asking about it?
Yeah,
Not
Krishna
yet.
talks about it a lot.
We have started discussing in meetings.
He asked about the patients asking about it. I don't think our patients.
No, I don't think patients are asking about
Patients aren't
kinematic.
asking.
No.
But I think so. Even joint replacement surgeons don't understand. So
Patients are asking for gold knees. Gold knee.
Gold knee,
Correct.
yeah.
They are asking about gold knees. Yes, correct.
When I was in India a few years ago, somebody asked me about the gold knee, and I had them take their 24-karat ring gold, 24-karat gold ring off of their finger, and I bent it. And I said, "Do you want this in your knee?" He said, "No." Exactly.
So Krishna, you can talk about kinematic.
We are using robotic assisted.
You're breaking over, Krishna.
You're breaking up.
Can you? I'll switch off my video. Maybe.
Video switch kar de, Krishna.
Yeah.
Yeah.
I think there is some disturbance.
Can you hear me now?
Yeah,
Yes.
yeah, Krishna.
Yeah. Okay. So we are doing quite a bit of restricted kinematic alignment in our practice with robotic assistance. So and we have set our limits at plus or minus 3 degrees of coronal plane obliquity, reciprocal to each other. So typically it will be a 2 or 3 degrees valgus femoral cut and a 2 or 3 degree varus tibial cut. And we tend to maintain the mechanical axis plus or minus 3 and maintain a combined sagittal angle of around 10 degrees, including femoral flexion and tibial slope, and a combined rotation which is between 0 and 5 degrees based on what we map on the thing. So we notice that the need for soft tissue releases are much lesser, and we're tending to use a 0 degree rotation for the femoral component most of the time.
So I think so. You need technology for all this. I don't think so. This is possible with manual traditional jigs.
Yeah. Regarding conventional kinematic alignment, most of the Indian patients are outside of that permissible limits. Like most of the tibia are more than 10 degree varus, and distal femur is more than 5 degrees of valgus. So I don't think you can do any sort of kinematic alignment in 50 to 60% of the patients.
See, but I would argue that in that patient with that degree of varus deformity of the tibia and curvature of the distal femur, if you just create a well-balanced total knee, you've done a kinematic alignment for them because you've recreated their natural anatomy.
Yes, most of the time.
Most of the time they are slight varus.
Yeah.
That is patient-specific alignment, probably. That's
yes, exactly. But again, ultimately, good balance. If you balance the collateral ligaments, then even with the what we consider a misaligned total knee for that particular patient, because that's their natural alignment. If the collaterals are balanced, it will work very well for them with good longevity. I would suspect.
So, no, that's what Krishna is saying, is that we all want collaterals balanced, but in many cases we release the collaterals to balance them. Whereas with Krishna's way of doing it, and I also do the same way, we don't do anything to the collaterals. We actually do all the modifications in the bone cuts so that our collaterals are balanced. So we cheat on the bone to balance the collaterals, where we don't release any collaterals as far as practical. Yeah.
But which makes sense, because you're doing an intra-articular correction of
it's all intra-articular correction,
as opposed to extra-articular, which is what mechanical alignment demands.
But you are keeping it within the range of 3 degrees.
5 total. When you can cheat 3 on tibia and 2 on femur, so total 5 degree you can cheat. If after that you need some sort of osteotomy or sliding up and down osteotomies. But that you can decide beforehand, because it is like a virtual operation you are doing beforehand.
So to give a clear message, it is not so that you are any amount of deformity you will accept. You are keeping it 3 degrees within the 3 degree range, varus or valgus.
So I don't want to confuse, but there is a South African surgeon who is even correcting to 11 degrees, and that was beyond us, because the implants look very funny. They are not manufactured for actually these sort of procedures. The implants are manufactured for mechanical corrections. So when you start putting them in these sort of corrections, they always look very odd on axis. And the more you take this odd, the more odd they look.
That's true.
But I think Dr. Rajiv has a very valid point, that we should not go home with a message that you can, leave the deformity where it is. And currently, although we tend to play around with the joint line obliquity, a little bit reciprocal on this way and that with the availability of technology, mechanical axis must be within ±3. And Dr. Raj's messages that we should balance the collateral ligament both in flexion and extension must also be taken extremely seriously, because the weak link is the polyethylene. And for the young surgeons, I tend to get concerned, because I was on one of these meetings with CAS, and then there was this Chinese surgeon who left the knee in 10-15 degrees of varus, cutting the femur in 5 degree varus and tibia in 5 degrees, no soft tissue release. Pre and post-op x-rays looked same. So one must not confuse kinematic alignment with a deformed post-surgical x-ray, or a mechanical axis which is outside the range which is acceptable for the polyathlete.
I think for Krishna, for young surgeons, they should not go anywhere near kinematic. They should stick to mechanical, I think.
Yeah, I think that's a valid point. Yeah.
Actually, to start with, they must know what is the standard and what's the neutral, and from there on, they can start doing all these various different alignments.
And Raj, one of the last things that do you accept would you like to give this message to our viewers, that the tibial tray, the cobalt chrome, highly polished cobalt chrome tray is far better than a titanium tray, especially in relation
to... Again, I would say in mobile bearing, yes, for sure. I think that in fixed bearing with a good locking mechanism, I think they're equivalent.
But
that would be my take.
You're not much worried about the underside wear in a titanium, which is not highly polished.
Yeah, we just, with the modern locking mechanisms, we just do not see backside wear anymore.
And better polyethylene, of course.
Of course, better polyethylene helps.
3 things work there. One is the polished tray, better poly, and the robust locking mechanism. These 3 things, and backside wear is almost gone. It's not there.
Yes.
I would also suspect that the stress shielding with cobalt chrome will be larger than titanium. So in fixed bearing, I would prefer to use a titanium base plate, which is cheaper, when there is no purported advantage with respect to backside wear.
Yeah, that's true.
The cost is the issue now, Krishna, because the government has fixed the cost now. So it is the same cost, I think.
No.
Titanium trays are more expensive.
Yeah, it's the other way around. Titanium is more expensive, and that is why the cobalt chrome, though it takes more costly to actually manufacture, has disappeared. You don't find any more cobalt.
They are withdrawn from the market.
They are withdrawn from the market in India. Yeah. You don't get them.
Don't get them now
because they can charge more for the titanium.
Yeah.
Okay, so
use cobalt chrome.
We will officially close this
session.
And before closing, Ashit, can I just take show this slide, one slide?
Sure, of course. It's all yours now, Rajiv. Yeah.
For our case meeting. that Rakesh is having Rakesh is organizing the next webinar, which is July 15th. Periprosthetic fractures around the hip and lessons learned. So with this, Rakesh, it may be serving just as a reminder to you as well.
Yeah, it is actually. Thank you.
So we'll close this webinar officially.
Okay.
Thank you for the invitation.
Thank you very much, Raj, and thank you very much for staying till late.
Yeah,
and
wonderful to
discussing
have
with
you,
us.
Raj. Wonderful to
Yes.
have you.
Thanks,
Great.
Thanks, Raj.